it's exactly that, where they come to us and say, who in the Valley is a specialist, or who in Arizona is a specialist in my disease, because I have a reoccurrence, and it's stage whatever the stage they want to give them, and I don't know where to go. So the first question that I ask is, did your oncologist talk to you about clinical trials? No, they haven't. So that tells me that they're general oncologists, they're community oncologists, and not to marginalize them or anything, but I think that the conversation needs to occur when the diagnosis occurs, the first diagnosis, the initial diagnosis. That's when really that encouragement needs to occur, and I see it on a daily basis that that's not happening. So from an organization like ours that tends to advocate for these kinds of things, I would advocate that we as society, or even as concerned myeloma citizens, we need to advocate for that conversation to occur, so the patient doesn't run out of options, or the patient doesn't see the clinical trial as the last option, like Jeff was talking about.
Sure. It seems like obviously to have a new drug approved by the FDA, it takes 8 or 10 years, let's say, and $1 billion or whatever. And so to speed that process up, it seems like the earlier you get patients into the trial, you're also speeding up their care, so that if you're speeding up their recovery or their ability to live with the disease, that you're also simultaneously speeding up the process to move through the trials as well.
So these are also better patients too, because each time a person gets a therapy and then relapses, that cancer has built up resistance to that whole class of drugs. So if you've relapsed, they put you on a different medicine, you relapse again, you've built up resistance, your cancer is essentially stronger by that point. So then if you get into a clinical trial, you've already got 2 strikes against you. So earlier patients are probably the better patients, but for phase 1 and phase 2 trial studies, those are patients that are usually farther along, there's not a whole lot. It's the phase 3 where they begin to compare, So there are different studies, but for a patient, it really is better to give them to the best therapy, first line therapies. Yes?
Yeah, it's important to realize that it takes a lot of work to put a patient on a clinical trial. It takes time, and if the physician is unable to spend that time getting the patient on study, then it just doesn't happen. And then the other point, as the patient mentioned a little bit ago, it's a challenge for the patient to travel to the center where the trial is being run, and the time and the efforts and so forth. And if it's a person who is working full time and doing well clinically, they just don't have the time to do it. One other problem is that new drugs, the physician in the center cannot give the patient a month's supply of the drug, or give the oncologist in the community a number of vials of the drug for injection. They have to be given by the center, and that makes it more difficult to get patients on study. So it's not an easy thing, even though both physicians and patients would like to see more on clinical trials.
Now, I was just wondering, has the advent of the internet really increased patients? Has the advent of the internet really increased patients' awareness of clinical trials?
Patients do.
Has the awareness of the internet really helped as far as patients' awareness of clinical trials?
By all
I hear
means.
that it has.
Yes, in a nutshell.
But only in certain patients. There's a selected.
The patient obviously must be knowledgeable enough to seek out and look at the information on the internet, and that, of course, would eliminate a lot of patients. The other thing to keep in one's mind is that multiple myeloma is a disease of older people. The average age is about 70 years, and patients above 70 less likely to be knowledgeable about the internet, number one. Number two, it's more difficult for them to travel and to make the effort to enter trials.
Well, this is actually a nice transition to our second question.
Just a quick comment on that. Probably the most innovative intervention that I've seen related to the internet, there's a woman named Susan Love, who, if you know about breast cancer, you'll recognize that name. She's very crafty. She put together a program, I think it's called Army of Women or something like that, where she basically has a database of women who are interested in participating in clinical trials, and any researcher who wants to recruit via this database simply gets on, writes a little proposal, and so on. So it's basically ready-made women, and it's everything from biospecimen type work to randomized clinical trials and so on. And it's really probably the most innovative internet-based approach that I've seen, proactive approach. There's really no reason why myeloma, for example, couldn't create a similar type of myeloma-specific process. And I can get you I'll get Barbara the exact details on that so she can put it on the newsletter or whatever. But that's a very good example of the internet.
Thank you, Jess. That's great. Okay, let's move on to the second. Any other questions? Any other comments? Jack?
A quick one. I wonder if Dr. Cog could comment on what you know about the difference between France and the United States and why there's such a dramatic difference between the numbers of people getting into clinical trials.
Well, the first point is that there are not oncologists in private practice in France, and when the diagnosis is made, the patient either goes to the university center or to a affiliated hospital, and that covers the patient population pretty much in the country. The second point is that in some ways the patient, I think, in France today is like the patient was in the U.S. a few decades ago. That is, okay, doc, whatever you say is fine. Now the patient comes, and many of them are very educated and very knowledgeable about the disease. The internet coming up in this fashion. And patients will have made a decision as to, for example, whether they want an autologous stem cell transplant or not. Some will say, yes, I definitely do. Others will say, I definitely don't. And the same with new drugs, new agents versus agents that are of proven efficacy. So there's not as much choice in France, in a nutshell, I think, that makes a significant difference. Plus the fact that the patient there is, I think, more likely to do as the doctor says.